Well, thanks for having us. I'm Eric Freeman. This is Bryan Hoelzer. We're pain specialists here in Utah County, and we're grateful that we can be here with you this morning. Our goal is to have a conversation about the sacroiliac joint, and specifically talking about how we diagnose pain coming from that joint, as well as different options as far as treatment of the joint. So, as is typical, we'll start with a case. We have a 68-year-old woman who 14 years ago had a fusion from L5 down to S1. She did phenomenal, really well for a long time. But just in the last 8 months, she started having pain in her low back, feels it in her buttock, goes down kind of the back of the thigh. She has this subjective feeling of weakness intermittently in the leg, as well as numbness that kind of comes and goes, but she's really, it's kind of a vague feeling of numbness in the leg. And so this patient shows up into your practice, into your clinic, and we'll go through the differential diagnosis. Right out of the gate, I'm going to take out the low-hanging fruit. That SI joint is one of the parts of the differential diagnosis. That one's not an option. Mm-hmm. What are the other things you'd think of if this patient comes into your office, as far as what are the possibilities? What are the things that you're thinking of that could be causing this? And we'll go back to the presentation there. So disc herniation. So nerve root impingement from disc herniation. Anything else? Stenosis. So stenosis, right? Give that transitional stenosis above a fused level or below it. Anything else?
Piriformis or hip pathology.
Yeah, piriformis, hip. It's crazy how piriformis will show up like this so often, but because she's fused, you automatically are thinking this has to be directly related to the spine. Any other thoughts? In this age group, you could have a deconditioning. So someone they're fused, in my age group, I'm deconditioned. So you got to imagine that she's got to be maybe a little bit more. Deconditioning could be a part of it. Myofascial syndrome could be part of it, just starting to develop some of that myofascial pain. Facet type pain could also be involved. You can get that degeneration above the fusion. So we have our several different options as far as what could be causing her pain. Here's the reality. The SI joint is literally and figuratively a pain in the butt for both patients and for clinicians. And it's because there's so much overlap in that area. You have so many other structures that could be contributing to this. And so each group will have a different approach to diagnosing SI joint pain. And the goal is to try and find out maybe tricks or tips that each group has, or each specialty will have, so that we can all improve our ability to correctly identify this condition. So if we start with the physical therapist in the room, someone comes into your practice, what are the things that you're identifying in order to say, you know what, I think this is SI joint pain? What are the things that you do? Yeah.
Palpation is one of the biggest things, like palpating the area that's actually painful and identifying that's the structure that's actually hurting.
All right, so tenderness to palpation. You're pressing on it and you're pressing right over that joint and it's tender. All right.
History helps a lot. I mean, the transition type pain, going from sit to stand, putting on pants. The fact that they had a fusion, that happens a lot.
So using the history and the fact of that transitional movement and changing position can trigger it. Awesome.
Usually patients will come in with one finger and be like pointing right to the area, and it's usually identifiable to a smaller degree rather than a big, huge, larger, dispersed area.
Awesome. Does anyone remember what that test is called? Fortin. It starts with it's an F word. Yeah, it's Fortin's finger. If you're going to come up with a test, like that's an awesome one. I just point to where it hurts. So if they point to it, then that's one of the tests. Anything else? Anything else that you would use to diagnose it from the physical therapy perspective?
I'm checking alignment.
Okay.
So I want to see how their alignment is in standing and in supine. So.
How do you do that?
I watch how they move. So I usually do standing hip flexion, watch how the pelvis moves, have them side bend, watch how the pelvis moves, the sacrum moves. Then I lay in supine. I typically have them bridge, and then I'm checking ASIS, pelvic alignment.
Okay.
So.
Awesome. Any other techniques that you'd use in physical therapy?
We look at also like obviously history, if they're pregnant before, like pregnancy issues, what their core control is like. So we'll have lay on their back and they keep a neutral spine as their legs move through like a supine march. We'll also use compression. So if you compress the pelvis, does that actually relieve your symptoms? So we use like a sacroiliac belt to add some temporary compression to give them relief.
So you'll use kind of an intervention or something that you do to help you get the diagnosis as well. Okay, good. Any other things that you would do from a physical therapy perspective?
You'd go through your special tests like Faber, thigh thrust, compression distraction, and gain time.
Awesome. So the physical exam portion of it.
Physical exam portion.
Perfect. Perfect. So if we add then our chiropractors in the room, anything different, anything you would add to that exam that you would say, you know, this is something that we do that we found to be really helpful as well?
I think imaging is important too. Weight bearing, flexion extension, weight bearing, dynamically ordering them to try to, I order these all the time where you have them try to touch their toes when they take a flexion and extension. Just go as far as they can. Also take, amen to everything else the same, but have they had any other like ankle injuries, knee injuries, something in the past that, you know, maybe some gait issues that could pertain to that as well. I think a lot of times we just x-ray to the pelvis, we'll x-ray thoracic region, other regions too, just to see what their compensating type of issues are there too. And MRI is very good as well, especially above and below, especially that, you know, the L5, S1 region is really tricky. They're so close and they have a lot of communicating nerves that are brothers and sisters right there. So those are all come into play, especially any type of ligament pathology that could be stress causing a lot of nociception.
And when you're getting your flexion views, are you looking at the SI joint or are you looking more at the lumbar spine?
Both. You can, especially at the lumbar spine, but you can kind of see what's going on. A lot of times the SI joints will have to do compensate a lot for what's going on. So if you can see some compensation of that, it does help.
The same thing with the imaging, looking at, like, especially looking at the lumbar spine, how much degeneration is there and how much it's fused on its own. I mean, if we know from surgical fusions that will cause an increase in motion in the SI joint, we see the same thing with degeneration in the lumbar spine, which that stress is still going to have to go somewhere.
Okay.
Because you can't always see what's going on in the SI joint.
Awesome.
Also, so as far as the special tests, mentioned the compression test. Take that a little further and sometimes have them do milligrams and have them raise both legs and then compress. And same thing, and that can relieve the pain.
Okay. Awesome. Thank you.
Leg length and quality. So a lot of times, so just sometimes doing those imaging as well to kind of see if there's that. But look at pronation of the foot as well can affect the SI joint. So patients always come and say they have hip pain. They say have hip pain, and then I say, where do you feel it? And they point back here.
Yeah.
So that's another sign to me that, oh, it's an SI joint.
Yeah, it's like, is it hip or is it hip or is it hip? Like, which one is it? I love the leg length discrepancy. Cause, patients will ask me, they're like, can you check my leg length? And I'm like, they get this blank stare of, I have no idea how to check your leg length. I'll get out, a tape measure or something, and it's not accurate. So that's something that we rely on each other to help with that. Pain specialists or surgeons in the room, anything different? Anything you do different to diagnose this?
How about an injection?
Yep. So that's what we use a lot for on our end. We'll end up doing an injection to, we think this is it, let's confirm it, and that's what we use. Anything else that you'd add? That was a great list. Great things. A lot of things I wouldn't think of typically.
Motion X-ray.
What's that, X-ray?
Motion X-ray.
Oh yeah, a motion X-ray. Yeah. Awesome. Thank you. So one of the big issues with it is the anatomy of the SI joint itself. It is really unique. It's kind of like the mullet of the joints of the body, because it has these two different parts that kind of contradict with each other, but somehow it just works. And so the top part of the joint is almost more like a symphysis. It's these really thick ligaments that hold everything together, and there's very little movement. But the inferior portion of the joint is a true synovial joint. So it has a joint space, it's filled with fluid, has articular cartilage and a capsule around it. And actually the articular cartilage has these ridges and depressions in it that hold it so it even stabilizes the joint even more. But because of this, it can be really challenging. And if you look at the distribution classically of SI joint pain, it's kind of this purple hue that'll be the typical description. Buttock pain is the most common, involving the lumbar spine as well. It'll involve often the posterior aspect of the thigh, and you'll even get some groin pain along with it. And so, as was brought up, physical exam becomes really important, and we use it a lot. In fact, we'll typically look for at least 3 positive tests in order for us to really be confident in the diagnosis. And so these tests were already brought up, the compression test. For us, how we do, we lie them on their side, and we push towards the ground in between the iliac crest and the greater trochanter, and push down. And if that creates pain, then we consider that positive. You can imagine, though, someone who has myofascial pain, they're going to have pain no matter what, just because you're pushing on them. The compression test, we have them lie on their back, for those who aren't familiar with it, and we push posteriorly on the ASIS to create a compression of that SI joint. I'm sorry, distraction. I was speaking of distraction test on that one. Faber test is where you bring their foot up on the ipsilateral side and put it onto the contralateral thigh, and you push down on the knee and then on the ASIS to create pain. When I first came to the area, I had an MA who was so amazed at Dr. Faber at Spinal Interventions, because she was convinced that this was named after Dr. Faber. And she was so utterly disappointed when I said, actually, it's an acronym for flexion, abduction, and external rotation. Dr. Faber is awesome, but this is unfortunately not his test. At Gainsland test, we move them all the way over to the side of the bed, and you'll have them lying supine, and you bring the leg posteriorly or back towards the ground to create pain. Thigh thrust test, where you bring the thigh up and hip is kind of in a 90-degree angle, and you'll push directly down on the knee towards the ground. There are so many more. We can go on and on and on. There's so many different tests. The reality is, it's been shown that if you have 3 positive tests, you get a specificity of 78% and a sensitivity of 94%. So they're pretty good at ruling it out, so at ruling it in. And the other aspect that was brought up is imaging. Studies are really mixed as far as how effective using only imaging is at diagnosing the SI joint pain. So X-rays, plain film flexion extension, CT scan is not great alone, but if you use SPECT CT, it's actually, one study showed that it was incredibly accurate. The problem is that's a lot of radiation in trying to get that test. MRIs are especially helpful when you're looking for inflammatory arthritis, so something like an ankylosing spondylitis, where you're going to see inflammation around the joint itself. And really what you're looking for is narrowing of the joint space. You're looking for osteophytes around the joint, sclerosis on both sides of the joint, as well as inflammation in that area, are what you're going to be looking for on the imaging side of things. The gold standard as far as diagnosis of SI joint pain is an intra-articular injection, a test injection, basically where you're injecting a numbing agent into the joint, and then you're monitoring their pain relief afterwards. If you get 70% relief for the appropriate period of time after that injection, then that's considered a diagnostic test that is positive, and you have your cause of pain. The problem is, even with that, you get a false positive rate of about 20 to 25%. So even with the gold standard, it's more like a silver standard, because it's not ideal. But it's what we use currently to truly diagnose it. The reality is, when it comes to diagnosing the SI joint as to the source of pain, it's not as simple as one thing. It takes the history, it takes the exam, it takes using diagnostic injections, imaging, all of it, therapies of what improves it, what didn't, and all of that together helps us to come up with an accurate diagnosis. And once we have that diagnosis, then we're ready to move into different treatment options.
Thanks, Eric. This has been an interesting morning. At no point in the preparation of this talk or in my travels up here did I think I was going to hear a comparison of the SI joint to a mullet. Furthermore, by a bald guy. So tonight, I'm going to write about that in my Treasures of Truth book for sure, so I appreciate that. So Eric did a beautiful job, I think, describing just why the SI joint's unique and why it's difficult to diagnose, and why these kind of meetings and the kind of care that's being established in this valley is really important, because when I send a patient for physical therapy, often I don't know for sure what's going on, or I'll get a call from the McLeans, or I'll get a call from Dr. Lee that'll say, hey, I think this is the SI joint going on. And so having other people that are putting their hands on the patient, that are involved in their care, and that are seeing the big picture is really, really valuable, because SI joint pain is misdiagnosed all the time. It's overdiagnosed and it's underdiagnosed, but it's missed often, and that's a real challenge. And so the more we're talking to each other and understanding it, the better we're going to be at identifying it. We're going to fast forward just a little bit and assume that we have made the diagnosis, that it's correct, that they've gone through all of the great conservative care that so many people in this room give, and yet they're still having a lot of pain from their SI joint. And it can be a debilitating process that even with all the best care doesn't get better. So what are some of the interventions? And we're sort of in what I would call an explosion of SI care interventions when it comes to surgical approaches to the SI joint. Some of them still lack data, and that data is being worked on. But I think it's important for anybody that takes care of patients with spine pain, particularly if they have a portion of their practice where SI is involved, to understand these therapies so that they'll understand what a patient is getting, what they're going through, what some of the pluses and minuses might be, because you'll see these in the community because there is really kind of, like I said, an explosion going on. So we're just going to just to make sure we stay on track, we're going to skip the conservative treatment, I think, but I don't want to skip it with the idea of, hey, SI pain, let's do an intervention. That's not really what I'm trying to promote. Really, most of these patients with the appropriate conservative care can get relief, but there will be some that don't. So Dr. Freeman just talked about kind of the interarticular injection. That's been the tried and true in the world of interventional spine and pain and physical medicine and rehabilitation. It's an interesting injection to perform because in some ways it's the easiest injection you'll ever do, and in some patients it's the hardest injection I'll do. So I do C1-2 facet joint injections. I'll do a C3 selective nerve root block. Those are, in many cases, are often easier than getting a true interarticular injection because it's a difficult joint in some cases to access, particularly if there's degeneration there. But this is what you want to do, a contrast enhanced, so that you can see that you're actually in the joint. If that doesn't work, what are some of the approaches? And now, when it comes to SI, if you hear people talk about SI fusion or SI stabilization, there's really three kind of global approaches, and there's really nuances within those global approaches. There's the lateral approach, which is the tried and true approach that has the most data, that's been around for the longest time. There is a posterior approach, and there's a posterior inferior approach, and all of them have select advantages and select or very key disadvantages. But what we're looking at here on the left is the lateral approach. It's been around for the longest period of time. Raise your hand in the room if you have seen a patient that has had this type of procedure done, lateral approach. Dr. Edwards, you've done this procedure. Tell us a little bit about what you, in your mind, are some of the things that you think are really beneficial about it, and maybe what are some of the downsides to it?
So it doesn't take long. It's less than 30-minute surgery, and it's a small incision. We've had good luck as far as safety goes, but there is a risk of affecting the L5 nerve root and the S1 nerve, depending on which implant you're putting in. The triangles have been around a long time. Some of the newer implants are a 3D printed screw that's a little bit less pain post-operatively because it's not as traumatic to put in. And the success rate in the literature and in our clinical experience has really been about 80%.
Yeah.
There's a lot of literature on it, and then we've seen about what the literature shows. I think some of it's maybe some patients have other things going on, or maybe SI wasn't really the right thing. But
Sure.
by and large, if we have the right diagnosis, the surgery is helpful. And the complication rate has been very low.
Yeah.
Very few, if any, infections. With the triangles, we had a couple of times where it fractured the bone around it a little bit, and that just created, I think, a prolonged postoperative pain compared to the normal. So those would be some good things.
So what I'm hearing is it's fairly fast to do, it's fairly reliable, and there's good data for it, which are all great things. I think we all live in that world when we treat the SI joint of patients that don't do as well as we were hoping, and was it because that was the only problem, and it's often that there's more than just the SI that's driving some of the pain. So you have to really set realistic expectations about other things going on. I'll summarize what you said, and you tell me if you disagree. One of the possible disadvantages is you're really traveling from an area of safety to an area of danger with these implants. So sadly, I don't do medical legal work, but sadly this week or next week I'll be doing a deposition, and I wasn't involved in this case at all, but I was asked to just comment on it where unfortunately they got into S1, and that patient has a CRPS type picture and a permanent disability because of that treatment. Now that doesn't happen very often, but you are going from sort of an area of safety towards the neuraxial area, towards the neuroforamen. So that's maybe a critique of it, but certainly has the data there to prove that it's the better way, or that it's the most common way to do this. There are people now that are kind of pushing the envelope with other approaches to this SI. So we're going to talk a little bit about the posterior approach and the posterior lateral approach. And so there are lots of options out there now for the posterior approach. I'm going to address 4 of them that are kind of a hybrid between them. There's this approach here that is done by a company called Aurora, which is the Silo TFX, and it's placed posteriorly into the joint. And then there are fairly smaller short screws, ilial screws and sacral screws, that help stabilize the joint. That's one option. There is another posterior approach called the Versa, which is kind of almost like they're trying to use like an artificial disc type approach to it. I was just talking to Dr. Anderson about it. Dr. Anderson, what is your opinion on that Versa, since you know a little bit about that?
Yeah, so it's kind of like an A-lift cage is what it's very much like. It's a titanium cage, and it's 3D printed, so it's meant to hopefully integrate well into the bone. And then you can see the kind of the little locking blades that come out from each end. Different than the lateral. I think one of the biggest differences between posterior and lateral is in the lateral, we're kind of compressing the joint and trying to close it together. And in the posterior approach, you're really distracting it and trying to get tension by opening the joint space, and then the ligaments provide that tension that occurs. And so this is meant to fit in there and kind of distract the joint open, and then hopefully promote fusion eventually. I mean, these are fusion devices. So the bone should grow across it. I think it's certainly more robust, the titanium and stuff like that, versus some of the allografts and stuff. That they're, that's just kind of another thought or another camp of this that's a little bit newer that we don't maybe have as much data on.
Okay, so kind of what I'm hearing you say is that maybe it has a different function with the distraction, fairly easy to do, not super invasive. Data is just starting to come out with this device, and I think there still needs to be more data to really understand who's the right patient. It's interesting because there's a portion of patients with SI pain that it's SI joint arthritis kind of pain, and there's a portion of patients where it's more of a ligamentous problem. And so that's one of the debates is, if you compress, do you help the ligamentous patients, and if you distract, do you help the arthritic patients? And I don't think we know the answer to that. It's going to be something that we'll have to decide. But people estimate it's somewhere in that 25 to 30% range that it's more of a ligamentous problem. This joint functions a little bit like a suspension bridge, and those ligaments are what's supporting that bridge. And so if the suspension's all jacked, the joint's going to have a difficult time healing. So that's an interesting point of view. So I like that you brought that part up. Another one here that you can see, this is the least invasive option. This is a pain tech. This is a cadaver allograft. It goes in. I would say I've done a number of those cases. I would say the advantage to them is it's a very simple case to do. Once you're, you never want to get into how quick you can do procedures, because I'm always bothered by that when you hear people say, I can do it in 12 minutes, I can do it in 10 minutes, because really what matters is you do it right and however many minutes it takes to do it. But this one's about a 12 to 15 minute procedure with a really, really small incision. The advantage of this one is possibly just how quick the recovery is. So I have, for example, an 89-year-old patient who doesn't have a lot of family support around her. She can't really tolerate a general anesthetic. This can be done actually just under local and with just like some light sedation like Versed or fentanyl, because it's so minimally invasive. So one advantage to that is just if you have a patient that's maybe not going to tolerate some of the rehab or some of the other challenges or some of the anesthesia that might be used for some of the more invasive approaches, it can be a good one too. They just recently published some 12-month data that shows really positive outcomes. And so I think it's interesting to see that you've got kind of your least invasive, probably to your most invasive now being the lateral approach with the 3 bolts, but I think everyone's still debating. And then there is one that I want to make sure we just have a minute to talk a little bit about that's kind of a combination of, I would call sort of almost a combination between the lateral approach and some of these less invasive posterior approaches. And this is a posterior inferior approach or an inferior posterior approach, depending on how you want to describe it. But this is the Tenon that Rob kind of raised this. And by the way, reps for every one of these things I think are here. The Versa rep is right here. The Pain Tech rep, Josh, is right here. We've got our SI bone rep here. At the end of it, we're going to have them do Indian leg wrestles. Whoever wins, that's going to be, because I figure that stresses the SI. So whoever wins that, I think is going to be is how we'll just decide how to go forward until we have more data. But with the Tenon device, and I've done a number of these cases too, and these patients do remarkably well. I think one of the advantages of it is there's really no doubt about fixating the joint, because you are drilling into the ilium, you're drilling into the sacrum. I think one of the big advantages of this procedure And this is what we're learning about the posterior approach. If you understand the SI joint, and a lot of people talked about the imaging, if you get a CT scan of the SI joint, they're remarkable how diverse they are. I mean, there's almost not any one SI joint that's the same, and some of them are more linear, some of them do a 90-degree turn halfway through the joint, some of them have a really tight inferior portion of the joint and a large recess at the top of the joint, and all of that changes how and where you would put one of these implants and how and where they would be successful. I do think the advantage of the Tenon approach with the posterior inferior is that you sort of traverse the entirety of the joint, and it's kind of nice because when you finish, it's pretty easy to see as long as the sacral side is on the sacral side of the joint and the iliac side is on the iliac side and it's placed at the appropriate depth, you can be pretty confident that you have fused that joint together. And it's interesting because it's a little bit, I don't know what the answer is, because some talk about compression, some talk about distraction. I don't know that this does either one of them, and so as the data comes out, it'll be interesting to see which one gives patients the best outcomes. But I have done a number of these, and the patients have done really pretty well. But it is a little longer recovery and a little more invasive than like a pain tech allograft, so there are advantages to all of these. The reason why I'm bringing this up and we're not showing a lot of data, what I'd like to do is come back in 1 or 2 years and say, okay, now here's all the data comparisons between these, because we all want to practice evidence-based medicine, and we need data to do that. But I wanted everyone in the room to be kind of aware of these different approaches and what some of the advantages and disadvantages might be, because you'll see these in your practice. These are not like, hey, maybe these will happen. These are on the market, they're being done, and so you should be familiar with what we're dealing with and why these different approaches are there. And if you're ever unsure, getting on the phone and calling Dr. Anderson or Dr. Edwards or me or Freeman or anyone, just saying, hey, tell me a little bit about what did you do to this joint and why? Because I do think eventually we'll start to have a better idea of what the physical therapy and rehabilitation should be after these different approaches, because we have no idea about that at this point. And with that, I think we'll start to pause and open up for questions. It goes to 7:30? Okay, good. We're right at 7:30. Questions?
This is probably an elemental question, but why does a fusion help the pain? Or what does it do to make the pain improve?
Dr. Edwards, what's your opinion on that?
Well, I think that I think that there's probably reality of some joints being unstable,
Yeah.
and others arthritic, and so if you fuse, you're eliminating an arthritic segment, or in the case of instability, an unstable segment. There's not a lot of natural motion in the joint, although I think that the motion is good if it's not painful.
Yeah.
But that's the best I can think of.
It's also interesting that, and I'm curious on some of you guys that have done the lateral approaches, I've seen patients before that they've had for years and years bilateral SI injections and bilateral SI pain, but one side clearly much worse than the other, like 70% the right side, 30% the left side. You only treat usually typically one side, at least that's what I've seen. I don't know about you guys. It's interesting to me how many of those patients, by just stabilizing the one side, the other side doesn't seem to be as problematic for them before. So you think of that sort of dynamic chain that we talk a lot about. I don't perfectly understand that, to be honest. I don't know if you guys ever see that in your guys' clinics.
So with this conversation, I think it's important to, when we're trying to diagnose the SI joint, to look, it doesn't have a lot of motion, but is it hypermobile or is it arthritic and without motion? And so which one it is, and so looking at the biomechanics of the whole region to try to determine that.
Yeah.
And then that can help guide our treatment as well.
Yeah, and I think that's going to be one of the subtleties, hopefully in the next 10 or 20 years, that clinicians in general start to understand better. Okay, this isn't just SI pain, it's SI pain because of some of these subtleties you're just describing. I think that would be helpful. You figure that out, Matt, and I'll be excited to read the paper. Or Gordon, it's fine if you do it too. I don't want to take it.
No, that's all right. I'm the older guy, so it's okay. Sagittal balance, kind of, that's what I mean, you're talking about what type of patient do we have?
Yeah.
Or, they have problems with gait. There's so many things involved, and if that sagittal balance is off, that's going to affect the spine, which is then directly going to affect the SI joint the same way. So we have to take all that into consideration. We have a tendency to focus in on the joint itself and not realize what's going on with the rest of the body.
Yeah.
From a biomechanical point of view.
Absolutely. Good point. Yeah.
I'm curious about this plate here.
Oh.
How do you achieve fusion with that? You're just putting a plate across the joint.
If we would add more slides, the joint, the plate itself is fenestrated, and then DBM is packed into it. And then also when you make your pontoon drills, you're taking some of the patient's bone graft, and putting it into it. So I didn't want to get too into the details of each one of them, what they look like. We could probably do that. We could probably have a whole talk, at least 10 minutes on each one of them, and what the designs are interesting, but it does achieve fusion. If you look at there are some studies with the post-op CTs.
Is the main decision making between lateral and posterior that it's either arthritic or ligamentous?
We don't know the answer to that yet. That will someday be the case. The main reason why people started looking at posterior approaches versus the lateral was to have a less invasive. I mean, the way that you've seen how the sacrum runs, it's very superficial to get to the SI joint from the posterior approach and quite deep from a lateral approach. So the thought was shorter surgery, less recovery, and less risk because you're going away from areas, because like even with this one, you're drilling away from the sacrum towards the ilium, away from the neuroforamen. Now again, in hands that are very, very good, the safety profile is remarkably good with the lateral approach. However, people were pushing the envelope to say, couldn't we get even better as far as the safety profile?
Lateral approach is like the most popular approach.
It's the tried and true with the most, I want to make sure I emphasize that, 20 years at least with a lot of data to it.
One comment here is that the surgeons might be more familiar with the lateral approach, but I think that the pain doctors that have historically done injections, which are done through a posterior approach, are more familiar with
Yes.
And it's all about interpreting your X-ray on these procedures, knowing exactly what you're looking at in 2 dimensions, in a 3-dimensional space. And so I think that SI is a wonderful topic because it brings everybody in the room here together, and then there's even a procedural aspect of it where there's overlap, and trying to sort out, who wins the turf war there, or really, because I think in our community we've learned that it's great just to see the patients get better, and whoever is the most appropriate for a particular situation is the way to go. But a lot of the decision making ends up being the clinician's comfort level with the approach, but in a community setting, we can actually, I think, more and more cater to what's actually best for that particular patient.
Yeah, so that's a great point, is what you're familiar with. If you're a hammer, all the world's a nail. So if you have a certain approach, you tend towards that approach. Todd, you were going to say something?
Yeah, number one is a fellow ball, and I love the Miller comparison. So
Yeah.
that was the right
That was the right move. It was clearly the right move.
I think the second thing, I think the data actually would be a lot better for these surgical treatments of SI joints if we are properly diagnosing them, which I would put my plug in for SI joint injections. We know for hip pathology and an intra-articular hip injection, successful one, the outcomes for a successful total hip replacement go through the roof.
Yeah.
And I think if we're really diagnosing it well with a diagnostic injection, plug for Southwest Pain and Spine, then I think that they're going to be better, and I think our outcomes are going to be higher. So I think just thinking of the ways that we can really pinpoint that diagnosis, I think these surgeries are successful. It's just, are we?
You got to get the right thing. Yeah, absolutely right. I think that's a good point. And we love doing your diagnostic hip and SI injections, and we're here from. No, I'm just kidding.
Question from an injection point of view, looking at the MRI, CT scan, the difference between the arthritic versus the ligamentous type or the pain generator. What's your experience in there if you can compare one from the other? In other words, did they seem to respond better to the injection, say if you felt it was more ligamentous versus arthritic?
If it's my opinion, and I've never seen any data that absolutely describe this, is if it's truly an arthritic joint, if you can get a pure spread of interarticular contrast and use local only, because we all know that steroid has a little bit of, I call it the napalm effect. It's going to go a little bit everywhere. So a truly interarticular like that one you saw, with a small volume, about 1 to 1.5 cc's of local anesthetic, is really indicative of an interarticular problem. The challenges with the SI joint, like Eric described, is it's not always a true joint. You actually can get spread in a number of patients. We've had some patients before we've done SI, and they're like, my whole leg's weak. And I'm like, I used 1.5 cc in your joint, but the anterior capsule is often doesn't have true integrity to it, and so you can get spill onto nerve roots, and you can also get spill posteriorly into the ligamentous area. So that's what makes it hard. And so if your contrast stays interarticular and it's perfectly interarticular, you can be pretty confident. I don't know what Eric would say, but I would say at least 20% of the time to 30% of the time, I have an interarticular spread with some periarticular spread, despite all my efforts to be only interarticular. Yeah. Eric has a little less, he's a little better than me, but mine's about 25 to 30%. His is 10 to 15. This was, I think, a really great discussion. Oh, go ahead.
I was just going to say, I mean, I think if we just continue to remember that this joint, arthritic or not, is, you know, in most cases, has movement, doesn't have movement, it is a tight joint. So the fact that you guys are even getting a needle inside of an arthritic joint to begin with and getting a CC in there that doesn't spread, I think is, you know, that technically is baffling to me, the fact that you guys are actually getting it done, and amazing that you can. And so, like, I think that in injecting arthritic joint at times, like, I think you're going to get relief from that, just because if it is arthritic in those situations, that's going to be quite painful.
Yeah, yeah. It's a tough injection to do, frankly. It doesn't seem like it should be, but it is. Thank you all for your comments and attention and for all you do to care for people in this community.